Hello, everybody. I'm Polly Dawkins, Executive Director of the Davis Phinney Foundation, and I'm here with our dear friend and amazing movement disorder neurologist, Dr. Jori Fleisher. Hi, Jori.
Hey, Polly. Thanks for having me.
Well, thanks for being back with us. Today, we are going to be talking about understanding the basics of advanced care directives or advanced directives and long-term care options for care partners and for people with Parkinson's, um, including the topic of what happens when care partners develop serious health issues as well. So to start off, before we jump into this topic, which may not be all that exciting, but is incredibly important to overall well-being and well-being of your sort of your mental health and reducing anxiety around these topics and being prepared. So before we get into that, Dr. Jori Fleischer, welcome back, and please introduce yourself to our audience here.
Thanks so much, Polly. And thank you to everyone for logging on, especially to this topic, which can be really intimidating sometimes. I'm Jori Fleischer. I am a movement disorders neurologist at Rush University in Chicago. And I'm really fortunate that my clinical practice, for lots of different reasons, has kind of shifted towards taking care of folks with more complex later stages of Parkinson's and Parkinsonism. And I get to work with a really special team. And every Tuesday, we have a special clinic that is really devoted to helping folks kind of cope with and adjust to and understand all the changing symptoms and how they should plan for the future. And that includes a lot of discussions about advanced care planning, advanced directives, all these different legal documents. But really, what's more important is the conversation around what matters to people and how do we plan for the future to make sure that what someone wants is what they get, right? And also if there are things that someone doesn't want, that they're not at risk of, having those things happen. So I think that's why.
Yeah.
Sorry.
So that's why being proactive and thinking about this ahead of time is
Yeah.
important. All righty. Well, let's start off. And sorry, before we jump in, I want to remind folks in the audience that we have many other sessions that Dr. Fleischer and I have done over the last 18 months together. And we will be doing a few more sessions this winter. So if you like what you are hearing and you want to dive more into other topics, we'll list a link below how you can find those extra sessions. Super. So, Jori, to start us off, can you tell us what is an advance directive and why is that an important thing for Parkinson's care partners to be aware of?
Absolutely. So an advance directive is really a legal document that either designates who a person wants to speak for them in the event that they can't in terms of their healthcare, their medical wishes, or what they want or what they don't want. And so commonly the WHO document is what's called a healthcare power of attorney, HCPOA, or a durable power of attorney for healthcare. And sometimes this gets confusing because people will use the term power of attorney or POA, and that can cover financial decision making as well as healthcare decision making. So here we're really talking about specific paperwork that says, you know, Joe Schmo is my healthcare power of attorney. Um, and then the other one, the sort of what do I want, could be different documents. So that could be a living will, which kind of says, in either very general terms or very specific terms. In case of this, I want this. In case of this, I would prefer this, but not that. Um, or it could be something like a medical order for life-sustaining treatment or provider order for life-sustaining treatment, which, depending on the state, goes by a MOLST or POLST acronym. And we can talk about some of these different ones, but that is kind of a shorthand for in a crisis situation. That is more black and white. If I want this, I do not want this.
Super. And for clarity, if I'm a care partner, I have my own
Yes.
advance
This,
directive and my loved one has
yes.
their own as well.
Exactly. So everyone should have their own documents.
Mhm.
And, I'm always reassured when I'm meeting someone and I say, have you thought about this? Have you designated someone in case you're unable to speak for yourself for any reason, right? Um, and often our person with Parkinson's has completed a healthcare power of attorney. Then I look to their care partner and say, and what about you? And they're like, oh, well, I don't need to worry about that. Um,
Everybody.
everyone really needs to, everyone needs to worry about that. And it's the same way as like everyone needs insurance, right? This is there just in case.
Yeah.
And it's something that, we don't necessarily want to think about, but you think about it, you make that plan, and then you can kind of set it and forget it and know that in case of that emergency, there is someone or there is a plan, someone knows what I want, what I don't want, what's important to me and what's not, and can speak for you. And especially for our care partners, there's often so much planning around their loved one, but there's very little around themselves, and we want to make sure that they are doing that for themselves as well.
Yeah. That makes such sense. From your experience in clinic, when you run into a care partner who's struggling to create their own advanced directive and or choose the person who is going to speak for them, and they're worried that their person with Parkinson's might not be able to be that person, who do they look to? Can you give us some ideas of who they choose? And
Yeah, it's a great question. And for some people, I want to put the caveat out there that for a lot of care partners, their loved one with Parkinson's may still be the appropriate person and may, fully be able to make decisions on their behalf. So, it's not a blanket statement that if your loved one has Parkinson's, they should no longer be your healthcare power of attorney at all. But especially if we're getting into later stages, if someone is having changes with their memory and thinking, that's when we really want to, think again, dust off the old paperwork and say, does this need to be changed? So often this might be an adult child. Um, I know a lot of our care partners, have adult children and they don't want to be a burden. They don't want to bother them. They don't want to put this on them. Think of this as a gift to your family members that then you can have this conversation. They know who's responsible for making what decisions. And then you can have conversations about if they have to make those decisions, what decisions you want them to make, right? And then they're not in the dark, in case something, an emergency happens. If there isn't an adult child, we've had folks who have a sibling, and maybe their sibling is their healthcare power of attorney. It can be a neighbor, it can be a friend. We've had folks where it might be their clergy member or a spiritual leader who's their healthcare power of attorney. So,
great
I
idea.
think every couple of years, it makes sense to just kind of check in and make sure, number one, that you have that paperwork, um, that the person you've named in that paperwork knows or remembers that they are your designated decision maker, just in case. And if there's a big change to your health care or your situation, maybe letting them know, especially if it changes what you might or might not want, right? So that everyone is kind of on the same page. It doesn't need to be an every day, every phone call conversation, but it should be there periodically. And that person, whoever is the healthcare power of attorney, should have a copy of that document. And this is really important because for anyone, whether it's a person with Parkinson's, whether it's any of us, if you go into the hospital and you are unconscious, there's something going on and you can't speak for yourself, um, typically every state is different, and this may differ outside of the US as well. But sometimes, in case of an emergency, if there's someone with you, the team may just look to that person, even if legally they should be going down a specific chain of command. And so if you are married in most states, every state, I believe, your spouse or significant other is your designated power of attorney, unless you have paperwork saying otherwise. Which means that if you are a care partner to a spouse, significant other with Parkinson's, and they are not your healthcare power of attorney, you need to make sure that your healthcare systems have a copy of that document in place in their chart, that you let your healthcare team know. Because otherwise, if your loved one with Parkinson's is accompanying you, they will look to them sort of automatically to make decisions. So making sure you've got the person knows they're the person, and the healthcare system knows they're the person. They really need to go all together.
So when's the right time to start thinking about putting advanced directives and healthcare powers attorneys in place?
I think this is one of those things that it always feels too early until it's too late. So I would say today is a good day. And I think if we think about these things before there's a crisis, right? If we think about these when things are stable, right? That can make it a much easier conversation. So, I'm a physician, we've got physicians in the family. We've seen too many cases where people haven't, said what they wanted or said who would speak for them. And things can get really difficult and really challenging with lots of family dynamics. So, even without major medical concerns, thankfully, I've got a healthcare power of attorney written out. My husband has a healthcare power of attorney. We've got, the advanced directives in place because anyone could be in a car accident, right? Anything could happen. And so we want to know that each other knows what we want, right? And I think that's really important. And you can name on many healthcare power of attorney documents, you name your primary person and you can put a secondary person. So I've had, folks that are like, well, we've got two adult kids. I don't want anyone to feel bad. Or it's not usually something that people argue over. But maybe if there's someone, who's in healthcare or, who you feel like understands your decisions, that person is the primary decision maker, but you can name a secondary agent if the primary person is unavailable, right? And the same for financial. So.
So how do you go about doing this, Jori? Is it expensive? Is it hard? How do you do this?
A great question. So for healthcare power of attorney, each state in the US tends to have a form, and you can actually just go on your favorite web browser and type in Ohio, healthcare power of attorney, wherever you are. And you can download it. Um, in most states, they need to be notarized. They may need certain sign-offs, so it is a bit state dependent. But I would take a look at that and, you can sign it. Usually they need witnesses. The person who, is being designated as a healthcare power of attorney may need to be signing it as well. They can't sign as the witness and as the healthcare power of attorney. So I would just take a look at it and see what's required before getting everything together. But you can look at those, or you can go to an attorney. Specifically, like elder care attorneys are very familiar with doing this, but many attorneys, many lawyers may be able to help with this. Um, and then a living will is a different document. And each state has examples of living wills, but unlike a healthcare power of attorney, the living will can be basically anything. So we joke that this is almost like a birth plan. So there are folks that may go into the hospital and they come in with a binder of what their birth experience is going to be and what music they want playing at what times and what not. And we don't want these words used, but we want these words used and, these essential oils and things like that. And that is all lovely. You can be as specific as you want, but just like a birth plan, sometimes things change and sometimes there's an emergency. And so it may be better for a lot of people to think in broader strokes. So, for example, my birth plan was a post-it note that said, healthy mom, healthy baby. That's it. That was it. Whatever we need to get, whatever route we need to get there.
A good one,
That,
though.
right. And that
Okay.
was the goal, right? So your living will can be as detailed or as broad strokes. This is what matters, right? And so for some people, they may think ahead to the future and say, under absolutely no circumstances would I ever want. And that may be a whole host of things, right? And if there is something that you feel that way about, whether it is, artificial ventilation, being on a machine to help you breathe, I would never want someone to, shock me and do chest compressions, even if there is, a chance that I could recover. If I would never ever want that, then write that down. Um, If there are things though for so many people, things aren't quite so black and white. It's like, well, I don't think I'd want that. But if there was a chance that this could help, you can say those things that I would not want to be in a prolonged, state on ventilators if healthcare providers didn't think that there was a meaningful chance of recovery. Or, if I wouldn't be able to speak, if I wouldn't be, some of these are impossible to predict. But, if there are things that you feel really strongly about, right? Some people absolutely, absolutely under no circumstances will they receive blood transfusions, right? And that's something that doesn't budge. Then that's something that I would write down, right? But the most important thing is just like having an insurance policy, like a car insurance policy, but you don't have the card and it's not in the car, um, doesn't help if people don't know about it. So if you've designated a healthcare power of attorney, the person who would make those decisions, give them the blueprint for the decisions you would want them to make if you couldn't speak for yourself. So the healthcare power of attorney absolutely should have a copy of the living will. There should be an original that stays, in the house. Your healthcare team should have copies of this. I've had a lot of care partners that have the binder, capital T, capital B, and it's got, here is the medication list. Here's a list of my, physicians or my loved ones' physicians. Here's my healthcare power of attorney. Here's my loved one's healthcare power of attorney. You can separate it out, tag it, tab it, whatever you want. But, having a central place where all of those important documents live, um, and having family members know, okay, it's in the top drawer of, the file cabinet, whatever that is.
So we started this talking about advanced directive, and we've talked about advanced directive, we've talked about healthcare power of attorney, we've talked about living will. Are those all intertwined, or are they separate things? Or is advanced directive the umbrella? Tell us a little bit.
Advanced directive is the umbrella term, right? Is planning for the future and laying out, here is what I would want, right? I'm giving the directive for my future before it happens. And so that's both. Here's
Okay,
what I want. Here's who can speak for me.
super. Thank
Yeah.
you.
Yeah.
All righty. Let's talk about, unless we have forgotten something to talk about in those two documents or
Maybe
areas.
the one thing to think about is something that can fall under that category is what people refer to as DNR or DNAR, which is a do not resuscitate order or do not attempt resuscitation order, which is really a better term. And DNR is a small fraction of the idea of advanced care planning. Sometimes I'll bring this up and we'll say, you know, we, we're wondering whether you've, thought about the future and if, had any documents. And I've had people go, I don't have a DNR. I'm like, whoa, 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 whoa. But that is not the end all be all. What a DNR is, and it can be different if someone is inpatient in a hospital versus out living their life someplace else that is not a hospital. Okay. In a hospital is the simpler situation. So when someone is admitted to a hospital, the doctor, the admitting person, puts in lots of orders. This is the kind of diet that, the hospital cafeteria should be sending them. They should get this med. They should not get this med. And one of the things that goes in there is in the event of an emergency in the hospital during this admission, if this person's heart were to stop and they did not have a pulse, which means that, their heart has stopped, they will die. Do they want anything done to try to reverse that situation? Right. And for a lot of people, they'd be like, oh, of course they do. You're in the hospital. You want things better. Not everyone actually feels that way. And so the default, if no one has asked you, or if you have not said it, I think what's really important for people to know is the default all the time is to do everything possible to try to bring the person back. And I think that's really, really important to recognize is if, without that, the heart has stopped, that person is dead or is on the way to dying. And so any intervention is an attempt to resuscitate the person. Sometimes it is successful. unfortunately, ER and Grey's Anatomy and a lot of wonderful shows have misled the public a lot. And there's really interesting research around this, which shows that, in a lot of TV shows, the person is gone and you see the flat line and you hear that terrible sound. And then the team rushes in and they pound on their chest and, they're shocking them and they're doing all these things. And the person kind of, oh, oh, okay. Right. And it comes sort of right back to where they were. And while I wish that that was the case most of the time, that is a really, really unlikely scenario. Um, it is, depending on the situation, it can be very small percentages of people who get any pulse back. And that may require, pounding on their chest, breaking ribs, shocks to the heart, putting a tube down the throat to help someone breathe artificially because they're not doing that on their own. Right. And then being able to recover from there is a whole other journey. So the default, if you don't say anything, is the healthcare team will work as hard as they can to, attempting to bring you back. In the hospital, if someone says, I don't want that, I don't want someone pounding on my chest, I don't want them shocking me, I don't want, under any circumstances, you can say DNAR, do not attempt resuscitation, or DNR. And the hospital team, just as they're entering general diet or diabetic diet, will enter a code status that says DNR. And then that is on the chart so that in the unlikely event something happens during that time, they know how to respond. And they do what you want them to do and not what you don't want them to do.
That's an important topic. Not
That's
easy to talk about, but
yeah. Outside of the hospital is a really different story. Because if in the hospital, if someone's heart were to stop in the hospital, they're there. They're right by the healthcare team, right? And so you have the best chance of survival because you're right there. All the equipment's there. Outside of the hospital, often, we don't usually think about this unless someone is at a point where they're saying, I would not want aggressive interventions. We can complete something called a medical order for life-sustaining treatment or a provider order for life-sustaining treatment. It has different abbreviations depending on your state. Not all states have them. But this is a document that a healthcare provider will fill out, and it's basically a standing set of orders that the paramedics have to follow for someone who is not in a hospital. But this is something that basically the only way that they know about it is if this is displayed and easily findable in the home, so that if someone has an event outside of the hospital where they collapse, they're unresponsive, EMS is called, and they find that that person does not have a pulse. Just like in a hospital, the default is to do everything. They are going to check for a pulse. They are going to do CPR. They're going to do chest compressions. They're going to shock. They're going to get an airway. They're going to do all the things. Unless there is this order that is outside of a hospital that says, in the event that, I am found down and I do not have a pulse, do not attempt resuscitation. And it does not mean that everyone just kind of goes, oh, all right, pack it up. We're out. Easy day. Right? That is never what this means. What this means is they will do everything to make the person comfortable. So, same in the hospital, right? I think there's often this misconception that a DNR means we're doing nothing.
Right.
And it's not true. So, if you're someone where there is a concern about being found down or something like that, or someone who is at home by themselves for periods of time, if the care partner works outside of the home, or, they might be there with a paid caregiver who may not know exact wishes. If the person were to pass out, right, if they've got orthostatic hypotension where they might drop their pressure and faint, it can be really scary in an emergency to know what to do. They call 911 and EMS, paramedics, firefighters are trained to look at the fridge. Usually these MOLST or POLST forms are brightly colored. They're pretty hard to miss. And yes, it's not what anyone wants on their fridge. It's not what you want to look at every single day. But I've heard from a lot of people that once it's there and they kind of get used to it after a couple of days, then it's just part of the scenery. They don't pay attention to it anymore. right? And if it's peeking out underneath a calendar, if it's peeking out underneath something, or it's in the freezer, you can put it in a Ziploc bag, the document, and just put a post-it note that says POLST in freezer. They will see it and find it there.
Right. All right, let's shift to talking about a topic that might be even more complex and challenging, which is long-term care planning. Should we start by laying out what types of long-term care there are and what this topic means? Could you tell us a little?
Absolutely. So I think we think about long-term care when we think, a person who needs more assistance, more help with their activities of daily living, bathing, dressing, feeding, toileting, all those kind of things beyond what their care partner is able to provide, right? And that varies from person to person, care partner, and person with Parkinson's to person with Parkinson's. And it varies from community to community because depending on where you are, there may be more or fewer supports. So for some people, this can look like bringing in paid caregiving into the home, which could be for a certain number of hours per week. This could be a paid caregiver who lives in the home and is there kind of 24/7. They have to have days off. So they're not actually 24/7, but there may be someone who lives in and on their days off, there's someone else who comes part of the time and is there to cover those hours. This may be 24/7 care that's split among a couple of people. So sometimes people describe split shift, which might be a few folks who work 12 hours at night, a few folks who work 12 hours during the day. There are a lot of different ways to kind of split that up in the home. For other people, this may be in a different kind of living situation. So this might be moving from living out in the community to moving into an assisted living facility. And assisted living is kind of a middle ground. So assisted living may be part of a continuous care community, which means a place that offers independent living, basically apartments for older adults who have no needs but maybe want to downsize, right? And just want a smaller place, want to be in a community with other folks who are similarly, age, similar interests, whatever that is, but they're doing everything on their own. They're going grocery shopping, they're doing their meals, they don't need any assistance. Assisted living means a person usually has their own room, their own apartment, and they may need help with certain things. So maybe they can, get themselves to and from the dining room and they'll eat all their meals in the dining room, but they may need help with showering. So assisted living is not paid for by insurance. Assisted living is entirely out of pocket. And assisted living, I would think about as you're paying room and board, and then there's an a la carte menu. And so depending on the facility, it may be that, if you need help getting dressed in the morning, great, we can send someone to you. It's $50 for dressing assistance, every morning times 7 days a week. And if you need assistance getting undressed at night, that's, an extra charge. If you need help with showers, but the showers are only a couple times a week, well, then it's, this charge. And that can range, from one little thing at a time to maybe you're someone who lives in assisted living, but you do need someone there with you to help get you up, get you showered, get you moving, get you out to, breakfast, take your pills, things like that. So maybe it's you're living in an assisted living place and you have a caregiver through the facility or paid on your own separately for a couple of hours a day. And for a lot of folks that's kind of a middle ground and it's tough because it's more independence than skilled nursing to talk about next. Different than living out in the community and being on your own. It's kind of this middle ground, but it certainly seems like there should be assistance for this. It certainly seems like something that insurance we would expect helps out with. And unfortunately, it doesn't. So it is a pretty steep cost.
Is
And
that
for some folks, yeah,
is that the same for people coming into your home, that's not covered?
that's correct. So for the vast majority of people, paid caregiving is entirely out of pocket. If you meet certain financial criteria, which depends on both income and assets. So how much you have in your bank account and how much you're getting in a pension or social security or disability or things like that. So it takes both into account, which can be tough because there are folks that may have, assets that they're not drawing on, but they're getting very little and they're living on very little per month. And so you may not qualify and they say, well, that's because, you've got XYZ. And you're like, but I'm not using it. That doesn't help me on a day-to-day basis. Those are the rules. And no one likes these rules. No one at all. Depending on your community and depending on your financial situation, reaching out to your area agency on aging can be a great resource. And if you go to eldercare.acl.gov, G-O-V, eldercare.acl.gov, you can look up your area agency on aging, depending on where you are, and they can, tell you, here's what we have available. And, you might need to meet XYZ criteria, either for paid caregiving, or there may be assistance, or there may be certain facilities. And for some folks, the assistance that's available in assisted living may not be enough. For someone who needs help with multiple activities of daily living, they need help with, all of their toileting or all of their bathing or all of their feeding. That's someone who is more likely to benefit from a skilled nursing facility or a nursing home. Those are used synonymously. And I wish one of the questions, if we had a chat going now, someone would probably be typing in, are there good Parkinson's friendly nursing homes? I wish. I wish we need them. We really do. There may be in your area, places that are really more familiar, that have taken care of more people with Parkinson's and may be more sensitive. And that is something you can ask. So just like any place that you might go, if you were looking into buying a home, if you're hiring someone, you can do an interview with an assisted living facility, with a nursing facility. What do you offer? What does a day look like? What services? At what cost? How much experience do you have with Parkinson's? What's my role as a care partner, as a loved one? Are there visiting hours? What can I do? What can I not do? What can I bring in? What can't I bring in? All that kind of stuff you can ask. But in a skilled nursing facility or in a nursing home, usually people have their own room, or it may be a shared room, but not a full apartment. There are nurses on site 24/7, so there's more medical assistance available, and people can help with transfers, with toileting, with feeding, with bathing, with kind of all of those activities of daily living. They will administer medications, which is really important. But I think something that comes up often, especially for our folks with Parkinson's, is many facilities may not be very familiar with Parkinson's, and most facilities may have a really hard time with some of our complex Parkinson's medication regimens. And the staffing at a nursing facility is different than at a hospital, for example. So in the hospital, ideally, if I say, my patient is admitted and they need to get their Parkinson's meds at 8, noon, 4, and 8, and you should not vary from those times, right? For the most part, that'll happen. At a nursing facility, there's fewer staff. They're often pulled and stretched too thin. And legally, they have laws protecting them, saying that they have an hour window in either direction. So if I say 8, noon, 4, and 8, and you must not waver, they could give the 8 a.m. dose anytime between 7 and 9, and they could give the noon dose anytime between 11 and 1. And so that might mean someone goes from 7 a.m. until 1 p.m. instead of 8 to 12. It can be really challenging. So often that transition period of going into a nursing facility is a transition. And nursing facilities, depending on where they are and the types, coverage for that, some of that coverage may be through insurance. If someone has long-term care insurance, that may be covered. Sometimes you may have coverage for a certain amount of time based on Medicare. And then someone needs to transition over either to being out of pocket or apply to receive Medicaid. And then that may, certain facilities do or do not accept different forms of insurance or payment.
Jory, one of the things we hear so often, and that feels gut-wrenching to hear from our care partner community, is I don't know when it's time. I don't know when it's time to move my person somewhere else, or I don't know when it's time to bring somebody in, or maybe even more complicated, my person won't let somebody else come into the house
Yeah,
and help. Can you address some of those, sort of the guilt with it, the decision making around it? When's the right time? Some of those
yeah.
topics around
It's
long-term
so
care.
hard, Polly. Like these are such hard questions and they're so individual. So I think, the blanket answer is there is no right time. And there isn't necessarily a wrong time. Sometimes I think of it as there may be better windows. So not a specific day, not a specific, marker of, the symptoms are at this or their tap and clap score and, at the doctor. It's not that. And some of it depends on the care partner, right? So if you're working, in the house, out of the house, if you have other care partner, responsibilities, caregiving responsibilities for kids, for other family members, right? It may be that earlier on in the course of your loved one's Parkinson's, you are feeling pulled in so many directions that it's just impossible, right? So there's never a bad time to raise that hand and say, I need some more help. Right? Which is not to say that that's not difficult or it's not expensive. It is, but so is your own health crisis. And so is, your loved one having a crisis because, you know, maybe we waited a while and we thought that they were safer on their own for, longer than they actually were. So I think if you're feeling like you're struggling, if medications are being missed, if we're having falls that are unwitnessed, right? The person's kind of able to get up on their own, they're kind of unsupervised because it was just that 5 minute period where you went to the bathroom, right? You haven't taken your eyes off of them, in all this time. And that's when it happened. Right. Number one, you should be able to get up and go to the bathroom more than just those 5 minutes and not have to worry. Right. And if you are so worried that in going to the grocery store a block away, for 5 minutes, something might happen, that may be a sign that now it's time to bring someone in. Right? And I think it can be really difficult, especially if there are cognitive changes, especially if someone is starting to have hallucinations or delusions. Someone, with Parkinson's is really worrying that you're plotting against them or, things are going on. It can be very difficult to introduce someone into the mix. It can be very difficult to transition from home to anywhere else. So often when I see these early signs of someone starting to be a little bit suspicious, starting to maybe fall prey to scams or, phone scams or things like that, that's when I'll try to explore with the care partner, how's stuff going at home? Because it's much easier to introduce a companion, a friend, a helper. We don't have to call them a paid caregiver, right? We can call them whatever we want to call them. We should discuss it with the person, right? But bringing someone in at a time where it feels a little bit too early, is better than trying to bring someone in when the loved one is having a lot of suspicion, a lot of concern, really, really agitated. It's going to be really hard unless you find a unicorn, to get the suspicious person with Parkinson's to accept someone new. It's not impossible, but it can be really difficult. So, you know, think about it early, which is as much a financial decision as it is kind of logistics and everything else. But think about it also as kind of an investment in your own health as a care partner. It gives you some respite, right? And I think one of the challenges with bringing in a caregiver, helping hands, is what are they going to do? What what can they do? What am I supposed to ask them to do? Like it's someone in my house, like they're going to see my underwear, my laundry, stuff, right? And so, you know, People can hire someone either privately, you know someone, you hear of someone, right? And it's just a one-on-one, or you may hire someone through an agency, and those can be different. And the costs can be different, and there are pros and cons to both of those. An agency may be able, they may have firm things that say, caregivers may help with X, Y, and Z, and they may not do the following things. Whereas someone hired privately, you may have more flexibility. But thinking about what is it before they even come in, just like if you're going to hire anyone, what's the job description? I want them to help my loved one with getting dressed, getting ready in the morning, eating breakfast, doing those things, maybe preparing breakfast. Doesn't need to be a five-star meal, right? But it might be, can you help with getting, toast or eggs or whatever that is ready? It may be, cleaning up. Can you load the dishwasher? Can you take care of their plates, right? Not hosting a party the night before and hoping that they're going to clean up. That's outside of their scope. But the things that have to do with the care partner. But other really helpful things are if the person with Parkinson's has physical therapy, the caregiver can go with them. If they're able to drive, and that may be agency specific, right? They may be able to drive your loved one to physical therapy and not just sit there on the phone, right? Or hanging out, watching what's going on, taking notes maybe, and then being able to do those exercises with them on the non-therapy days, right? They may be able to go for a walk with them, go to the mall if it's cold outside, go walk around, go to the gym, go to see a movie, go do stuff, right? Are there hobbies that your loved one may have given up, maybe doing less frequently, and maybe they're things that you don't love so much, right? Maybe they really want to watch their old westerns and you would rather not. That's an awesome thing to do together with a care partner. And if that care partner can engage with them during that, so it's not as just sitting back and staring at the TV, but have you seen this one before? Oh, this one's new to me. What do you think is happening? Kind of making it as enriching as possible. That's the best way for that person to become trusted, to become part of your care ecosystem, right? Part of the family and accepted by your loved one with Parkinson's. And the more accepted and trusted they are by your loved one, you will feel better going to the grocery store and actually taking 30 minutes. You could actually walk around an aisle where you don't need something. You could go just take a walk, call a friend, do another errand, go to the bank, whatever it is that you need to do without that pressure of, how long. So
How about the topic of guilt? I hear that so much. Like, I feel guilty that I have to, or my person doesn't want to bring somebody in or go somewhere, and I'm dealing with this guilt. Any thoughts on
I
that?
think it's so common. So you are not alone in feeling guilty. And no one can do this on their own.
Yeah.
No one. And even, I mean, every single Parkinson's journey is going to look different, but no one can do this on their own, right? You've accessed this webinar, right? You've reached out to a resource. Hopefully, there's some pearl in here that's helpful, right? You may attend a support group and find things from there that are helpful and keep you going, right? Your loved one is not doing it on their own. Hopefully, they've got a healthcare team, they've got medications, they've got therapies that are helping make this journey easier. And hopefully, they don't feel guilty using those resources. This is another resource that helps you keep going because, I mean, as cliched as it is, this is not a sprint, this is a marathon. And we want you as the care partner being as healthy as you can be. Because if you are burned out, if you are hurting yourself and you're trying to spin all the plates, you are going to burn out, fizzle, get injured. And that is only going to put your loved one at even higher risk. And I think so many times I hear from my people with Parkinson's, like what matters most to you? And they'll say, I just don't want to be a burden on my family. I want to be able to do things and I don't want to be a burden. And so I think framing that as part of it is, I know you're not excited, for so and so to be here, but I need a breath. This gives me a breath. And then once I come back, how about we, whatever, right? And you can maybe you can watch the movie with them
The more fun
instead
things,
of,
right?
right? Instead of thinking, did you do your exercises? You need to do your exercises. I know because so many of my care partners, I hear this, that they feel like they need to take on not only all those activities of daily living, but did you take your meds? Are you sure you took your meds? Did you write down what happened with the meds? Did you do your PT and your OT and your speech and your big and your this and your yoga and your Tai Chi? You can delegate some of that. And it's so easy to say no to the person who's closest to us.
Yeah.
So the person with Parkinson's is much more likely when you say, as their loved one, whether it's a spouse, whether, it's adult child care partner, you know, Dad, you got to do your PT. Did you do your PT? Not today. I'll do it tomorrow. You really got to. You really need to. The doctor said, you're supposed to do this. And then there's that guilt of, I can't get them to do it. I know they're supposed to. I should be finding some way around this because if not, they're not doing what they're supposed to be doing. And then that's a failure somehow on my part. And that's never true, right? We can't make someone else do something. We can encourage them, we can help them, we can build scaffolding, right? We can't actually make them do it. And especially, we're most likely to reject the suggestions of the people that we feel most comfortable say no to, right? This is why kids can act out at home and then be perfect angels out with other people, right? They feel comfortable at home so they can kind of let it all hang out and have the temper tantrum, right? You're a safe person for your loved one with Parkinson's to say no to.
Such a good point.
So,
On the other hand, we hear from care partners that they're dissatisfied with the level of care that their person is receiving in long-term support, long-term care area
yeah.
facilities. What are any resources that you could suggest to help people look at the options and know whether they're actually getting good care or
Yeah.
substandard?
I think this is so huge, right? And it's a valid concern. It's a really important concern. I think it starts with, before someone, goes to a facility, if you have that luxury to be able to look around and do interviews, getting a sense and not just here's the formal tour and we look at the garden and we look at this, but can I meet with some family members? Do you have people who I could talk to whose loved ones are here? Not just what's in the brochure and what's, shiny, but can I talk to some other folks? Do you have any other families with Parkinson's
Right.
who I could talk to? Um, I think, that if you're able to do that before placement is really helpful. That that may not always happen, right? And then I think really important is um, realizing that the people who are there, as stretched as they may be, um, they want to be there. They want to do right by your loved one. So going in with that expectation of, I may not like or I may have heard that something's going wrong. I'm going to come in with the baseline understanding of they're doing the best that they can based on, the resources they have based on their knowledge and thinking about this as like, how can we partner together to find a solution, right? And so, my loved one keeps telling me that they're not getting their meds on time. They're not getting their meds on time. You could, you know, pull the alarm, call the CEO, write a strongly worded letter, and I'm going to call my lawyer and I'm going to do this. You could do that. It's probably not going to go as well as, you know, who, what are the names of the aides or the nurses who are usually on the morning shift and coming in, and it may not be the same person every day, right? So coming in, introducing yourself, explaining why. Right. I know that, you've got to have, how many patients do you have? You've probably, you're probably running around a lot of different places. And most medications, like the timing doesn't really matter. And I know that it won't be perfectly on time. I know legally that you have this window, but for Bob, for Jenny, if they get their meds on time, then they can actually feed themselves better when the breakfast tray comes. They can actually help, go to physical therapy and work with the therapist and get out of the, bed to get to the bathroom. If they're missing their meds, they may need your help to do that. They may not be able to do that on their own. And I recognize how busy you are, and they really want to be able to do this on their own. So do you think, could they be the first pill drop off in the morning? Or, what would be the best way to do this? Right. And I think starting with, going through the chain of command instead of going straight to the top. Because then it can be really hard because it kind of, pits people against each other. And there may be a really awesome charge nurse who, if they would have known that this was a problem, would have been like, oh, cool, I can easily fix the solution. At 7 in the morning, I will only assign them to these two people, and then Bob can get their meds on time. And, these folks, they'll be okay. Right. So I think thinking about solutions, working towards that, working up the chain of command, being there as much as you can, right? Knowing that it's going to be different and it doesn't make someone any less of a care partner, a caregiver, if their loved one is in a facility. It's different. It looks different. But I hear from a lot of care partners, they're like, I thought that I would feel a much bigger sense of relief, but I still feel like I'm playing air traffic control. And sometimes that gets better over time as the person settles in and they get into a routine and you get to know who it is. Um, that it isn't sort of a tag, now you're it, right? It's a partnership. And so, just the same way as if someone was coming into the home, you're going to kind of navigate what are those responsibilities and who's doing what and what can I ask and what shouldn't I ask. It's going to be a little bit of that dance to kind of figure things out. If, however, you are finding that, there are things going on that are just seem, outside of meds being delayed or things like that, loved one is falling. They're saying that they're not getting help. You're seeing signs of, injuries or bruises that you can't explain, that they can't explain. They're losing weight, in ways that you can't explain. Those are reasons absolutely to work up the chain of command, to ask questions, not accusing, but I'm concerned. I'm concerned. I'm noticing. I'm worried about these kind of things. And if you're not feeling like you're getting answers, asking to speak with an ombudsman can be a great place to start. That may be someone within the facility, that may be outside, that may be reaching out to that area agency on aging. But there are phone numbers to call if you are concerned about neglect or abuse. There are state reporting hotlines.
Thanks for those suggestions. Those are really insightful ways to navigate that.
We hope no one needs to go that route, but
No, but I think a little sugar goes a long way, right? In a facility and
yeah,
becoming friends with and cooperating, partnering.
right. And encouraging as much as possible, finding ways that they can see the person with Parkinson's as a person, right? So if it's possible, bringing photos into the room, bringing, examples of who they are, what they've done, what's important to them, who's important to them. It can be really hard. And often, folks who work in a nursing facility are caring for so many people. They may be working multiple jobs, long, long hours. And it can be really hard to go from room to room to room and see the person, um, in each room. And so all of these visual cues, right, playing the music that they really like, things like that can help the staff get to know your loved one as the whole person who they are.
Yeah. Thank you. So as we are coming closer to the end of this conversation, Jori, let's shine the light back on the care partner and our audience's health and planning for our care partner's own care. So as with advanced directives at the beginning, you said everybody should have one. And I'm sure as care partners, you all in the audience are thinking about your person's needs before you're thinking about your own. And any thoughts, Jori, on the idea of whether a care partner has a long-term need or perhaps gets ill themselves? Thoughts on what you've seen, how to navigate that better?
Yeah, I mean, I've had some folks, this isn't exactly an advanced directive, but I've had people tell me, I came up with a crisis plan. And sometimes this is, in people who have a medical issue where, they're really worried, right? Something has happened and they don't, maybe there's been a heart issue, maybe there's been a fall or something, and they've got a crisis plan. And that might be a phone tree, of if something happens, I call neighbor, sibling, adult child, whoever it is, right? Community member, maybe my support group leader, whoever that is, you call someone and that person, either calls the next level of the phone tree to activate, you know, if care partner needs to go to the hospital, needs to go to the emergency room, here's the tentative plan for what happens with the loved one with Parkinson's, right? The neighbor next door comes over, and stays with them overnight, right? Or the adult child, who's nearby takes them to their house, or the adult child who is a plane ride away, is notified and can start to make plans. Or maybe there's a paid caregiver who's already in the mix, for a few hours. Maybe that's someone who, in case of emergency, can we call you, even if it's outside of those hours, if you're available, or the agency, can you send someone, in case of emergency? Um, and in that crisis plan should be sort of the one-liner of my healthcare power of attorney is, my loved one's healthcare power of attorney is, the paperwork is in the binder in the top drawer of the file cabinet, the MOLST is in the freezer, here's this, so that all of that kind of the passport shortcut, do not pass go, do not collect $200. Here is the bare bones of what you need to know, right? That there's a really straightforward crisis plan. And again, no one wants to think about that, but thinking about it, setting it up, and then actually sort of knowing like, okay, if this happens, we'll be okay, right? Like you don't have to be lying on a gurney in the emergency room, being wheeled into surgery and going, can you, right? We don't want that. We want you to be able to focus on yourself and hopefully that there are no crises. But
Plan for them
yeah,
and communicate with them. Yeah.
exactly. Right. You have to, it's not just having the plan, it's making sure that the people who are going to enact the plan know the plan exists and know what their role is. So, yeah.
Oh my goodness, we've covered so much in this hour and really important topics for our community and for all of us, really, no matter where we are. Um, Anything that you feel that we've left out or that you've thought about during this time that you thought, oh, I should mention this?
No,
That you
I just, recognizing that these are really difficult things to think about and that it's very easy to push them away. Um, I did think about two resources that can help make it a little bit easier. So we talked about, you can go online, you can look up and kind of DIY or use state forms. There are two really nice resources that I like that walk people through these conversations, these processes. So one is the Conversation Project, which I think is conversationproject.org, but I can look it up.
put a link up. That's
Um, yes, theconversationproject.org. And if people are familiar with the work of Atul Gawande, who is a physician and has written the Checklist Manifesto and a lot of really wonderful books, highly recommend. But the Conversation Project is a website that came out of his team's work. And really, these are conversations. These really shouldn't just be this is a piece of paper that lives in the binder. It's the conversation around it that's so critical. And so there are different guides, including, I believe there are guides in Espanol. There are guides for having these conversations with people with cognitive changes, with memory and thinking issues, or with dementia. Too often I hear from families, well, my loved one has dementia. So, we'll talk about this without them. And depending on a person's background, their culture, that may or may not feel appropriate, but we do want to make sure that the person, to the extent that they are able to tell us their needs, their wishes, what matters, that we hear that and that is included and that's front and center in any plans that we make. So I really like the Conversation Project because of that. The other one is Five Wishes, which is fivewishes.org.
good. Number five or the word
The
five?
word five, FIVE, wishes.org. And they have digital versions and paper versions. And I won't get all of the wishes right, but it's something like, what is my wish for who is making decisions? What is my wish for the kinds of decisions? What is my wish that people know about me, sort of now and after I'm gone?
Hmm.
What is my wish about how comfortable I might want to be at end of life, which sounds like a crazy question. So wouldn't we all want to be comfortable? But it's kind of getting into the nitty-gritty of if someone has a condition where they might be at risk of having a lot of pain, there's often a trade-off between, being awake and having as much awake time with loved ones and people around, but maybe being uncomfortable, being in pain, versus I really don't want to be in pain. I would rather not and maybe miss, trade off some awake, alert time with loved ones rather than, suffer and be in pain. And that's a really difficult thing to think about. And for most people with Parkinson's, that's not, you know, pain at end of life is not something that we deal with a lot. So I don't want to put that out there and have people worry about that being part of it. But it's something that, we may think about, and it's something that may come up in hospice discussions, for example. Is just kind of thinking about those things. But I think what matters most to the person, and whether that's something that's easy for them to kind of put down, post-it note or not, right? Or whether that's something that we need sort of guidance on that conversation. Um, those are helpful resources.
Those. I appreciate those. All right, we're going to close out our conversation today, inviting our audience to join us again. We have a few of these sessions planned for this winter. Invite us to come back again and join us. We're going to have a live Q&A also following this in late February. As well, we have a dozen, 10 or 12 conversations like this on very specific topics around care partnering that Dr. Fleisher and I did together about a year ago. So we'll include all the links for how you can find those. Thank you, Jori. Thank you for being here and for sharing your wisdom and your passion for our community with everybody.
My honor. Thank you so much, Polly. Thanks for featuring this as a topic, and thank you all for watching.